Thanks for the invitation, Nathaniel. It's a privilege to be here. It's particularly wonderful to see the amount of women who are here supporting men. Dr. Kundu showed on his slides. So that's particularly wonderful to see. So I'm a urologist at Rush, and I really focus on minimally invasive surgery and minimally invasive oncology, just like my colleagues. My talk is unintentionally quite similar to previous, but it'll serve as a means to reinforce what you've heard so far, so that when you see your urologist in follow-up visits, you know the kind of discussion and discourse that you ought to be having. So I'm going to talk about some of the screening recommendations again, identify some methods to screen smartly, discuss screening beyond PSA, and discuss how multi-parametric is incorporated into my practice, which is quite similar to Dr. Patel's practice as well. So who should be screened? As you heard before, the AU not screening men who are younger than 40 years old. Having said that, just on Thursday, I had a 35-year-old man come in who had a PSA done by his primary care doctor. So that was an entirely different discussion. We think that the screening should be individualized for men between 40 and 54, and that men 55 to 69 should participate in a shared decision-making process involving not only them, but any significant family members and the treating urologist or treating primary care physician. Men older than 70, it's debatable. And then the arguments against screening, as you heard before, is that many cancers that are clinically insignificant are going to be detected. It's expensive to do, and it's not effective in decreasing mortality if you look at previous screening practices. So you basically need to elucidate what a person's risk is. So there are some adjuncts to simple PSA screening that emerged, and these include PCA3 scores, 4K score, as you heard before. Another thing that I incorporate into my practice is Michigan Prostate score, and that's done at the University of Michigan Labs. We'll talk a little bit about that later. And the Prostate Health Index. And then there are two other tests that I'll speak about briefly that are not included on the slides, and those are the Select MDX and a new test called Epiphany. So PCA3 is a simple urine test. It can be used in men with a life expectancy greater than 3 years. Typically, it's been incorporated for patients who have had greater than or equal to 1 prior negative biopsy, and it's particularly indicated for PSA numbers greater than 3 nanograms per ml. It's also appropriate to guide the initial biopsy or the decision to perform an initial biopsy. Scores higher than about 35 are associated with a 2.5 to 2.7-fold increase in probability over scores less than 35. And this has been found to be independent of age, PSA, prostate volume, and digital rectal examination results. The 4K score, as you heard before, PSA is a kallikrein. These are similar compounds that are similar to that family of kallikreins. It gives a risk of high-grade prostate cancer being present. It's generally recommended to biopsy if the number is greater than 7% or the risk for high-grade disease is greater than 7%. However, that needs to also be incorporated into the decision-making process, because if a person is comfortable with a 10% risk of having high-grade prostate cancer and they're 68 years old, they may not want to pursue a biopsy for reasons that you've heard before. Michigan Prostate Score, this looks at gene fusion abnormalities within the prostate secretions, and also PCA3 and PSA, and this is incorporated into an algorithm that gives a risk of Gleason score greater than 6 and also a high-grade cancer risk. They use a logistic regression model to derive the scores for this test. The PHI, as you heard before, uses free PSA, total PSA, and pro PSA, and it also estimates the risk of prostate cancer outperforming any of the individual components of the test. I use the Vienna nomogram. As you heard earlier, prostates that are larger probably should get more biopsy samples directed at them. So we use a volume-based assessment. Think of your prostate as the size of a walnut versus an orange. If you take a standard 12-core set, you're likely to miss significant prostate cancers in the bigger prostate, and you may be more likely to detect small cancers that are insignificant in the small prostate. So we tailor the number of cores based on the volume and also based on the patient's age. So you've heard some about MRI from Dr. Patel. I think many practices in the city, not only academic, but where urologists are academically minded, we're looking for ways to decrease the burden of prostate cancer treatments and to decrease the number of insignificant cancers that are detected. So this paper is currently in press, and Dr. Pinto is one of the urologists at the NIH who has basically pioneered much of the MRI work that has been done to detect prostate cancer. And they've found that is rarely missed clinically significant prostate cancers. And if you look down here, the purported mechanisms are reader error, registration error, and this is registering the components of the MRI, intralesional heterogeneity, meaning that there's a lesion that shows Gleason 6, but there are also components of that lesion that have a higher Gleason score. And then there's the rare phenomenon of multiparametric MRI invisible tumors, which only happens in about 1.7% of cases. So here's an MRI. You've seen this before. You may need a bit of the eye of faith, but the cancer is right here, and I'll show you a little bit more about this as how it progresses. What does it really look like on the biopsy? So I think many practices now are fusing the standard ultrasound biopsy with the MRI results, and when you assimilate the MR with the ultrasound, you have areas that show multiple lesions. So this way we can accurately direct the needle straight into the target lesion, or what we refer to as the volume hotspot on the MRI. If we were to do an ultrasound in this patient, he actually did not have any lesion that we could see on ultrasound alone. So the MRI really significantly helps in detecting these lesions, and really helps in appropriately sampling the patient's prostate gland. So when cancer is seen on biopsy, what's the appropriate approach? Well, we need to assess the risk of metastasis and death from prostate cancer, because in the final analysis, that's what really matters, and we don't want to have patients falling into that over-treatment category, because we all think we're great surgeons, but every patient doesn't have an outcome that's ideal for them, and particularly ideal for their relatives. And a lot of it doesn't matter about how good the surgeon is. If you're in the 1% that has a bad outcome, you really don't care about the 99% that did extremely well. So we risk base on Gleason grade, the number of involved cores, the percentage of involvement, and then the overall stage. We also incorporate a fair number of genomic markers into how we help patients to select which treatment is most appropriate for them. So active surveillance in intermediate risk patients, this is also in press. I was lucky in residency. I trained in Toronto. Dr. Klotz was one of my mentors. Danny Vesprini was a radiation oncology intern when I was a chief resident. So I'm quite familiar with the Sunnybrook cohort, and as Dr. Patel pointed out, it's quite a different cohort from the Hopkins cohort. The criteria for screening, for selecting patients for active surveillance is a little bit more broad in Toronto. And if you look at this, they've included clinical T2C disease with PSAs up to 15 and higher Gleason scores as well. Now, a clinical T2C lesion is a significantly palpable lesion in the prostate, and I'm not quite sure that any of us in the panel, and this may be a topic of discussion later, I'm not quite sure that any of us would put a patient with clinical T2C disease on surveillance. Overall, if you look at it, the 15-year metastasis-free survival for Gleason score less than 6 or PSAs less than 10 was 94%, so that's pretty good. But then when you look at the higher risk patients, it drops down to 63%, which means that a significant number of patients are progressing to metastatic disease or not doing so well on the active surveillance protocol. And this may be an area where multiparametric MRI helps to detect those candidates that are more favorable for screening. If you remember Dr. Patel's slide with the patient who had a recent prostate biopsy which was negative and a lesion that was clearly in the anterior zone in an unsampled region of the prostate, that's probably an MR or radiographic T2, which is different from clinical T2. If that were posterior and you could feel it, that would probably not be a patient that would be a candidate for active surveillance in any of our practices. So things are definitely changing in this regard. Number of genomic tests out there to help stratify who's safe for surveillance protocols. Oncotype DX is a study that assesses a test that assesses prostate biopsy tissue. It assigns a score based on 17 genes that are known to predict the likelihood of high-grade or advanced prostate cancer. And the value of this test really is in selecting patients who should be guided or can be guided towards active surveillance versus intervention. The test can only be performed on Gleason 3+3 disease and 3+ minimal 4 disease. If there's a lot of 4 there, they're not going to run the test, but it certainly helps to confirm clinical risk stratification. The next test is from Myriad Genetics, Prolaris. The women in the group may or may not know of Myriad Genetics, but this is the company that had the breast cancer genomics test available for many years, and prostate cancer seems to trail breast cancer in terms of research by almost a decade, which is kind of embarrassing for us as urologists, but a lot more heavy funding has been dedicated to breast cancer research, and it's likely because women are more in tune with their health. The guys tend to stay away and not want to go to the doctor, particularly when rectal exams are involved. So this test looks at a 31-gene cell cycle progression score. And what the cell cycle progression really is if you think of one cancer cell as a mother cell that then divides and produces 2 daughter cells, which then divide, this is telling us how rapidly that's going to occur. And if that number is rapid or high, those are people who are likely to progress with their disease. And then final of the genomics markers commercially available is this Decipher test. This helps to predict the 5-year post-treatment metastasis. It also helps to predict the need for adjuvant or salvage therapy, and it gives us a 10-year disease-specific mortality and also the risk of high-grade disease. So, patient, as we discussed earlier, who's had a radical prostatectomy, the PSA comes back. This test can fall into that realm also, because there's a post-biopsy test, a post-radical prostatectomy test. and that can help guide the decision as to whether that person should go on to have radiation therapy or not, because they're risk stratified to be either high risk, intermediate risk, or low risk in terms of the PSA representing a significant recurrence. So here's a case, 62-year-old gentleman with no family history of prostate cancer. When we talk about family history these days, even that is sort of up in the air as it relates to prostate cancer, because if you consider folks in the 1990s who were screened with PSA, they underwent a biopsy, they had small amount of prostate cancer that we really wouldn't even think about detecting in 2016. Can you really say that if that person was your dad, that you have a family history of prostate cancer? So that's a little bit debatable. In any case, Caucasian male, PSA rose from 3.7 to 4.4. This was over a year. So what we're going to do next, we're going to assess his risk for having prostate cancer. So he had a couple of these tests. This showed an overall risk of any cancer being 48% and a risk of high-grade cancer being 26%. He also had a 4K score, and those scores correlated, so about 24% on the 4K score. He then went on to have a multiparametric MRI, and clearly the cancer is here and it's here. So we use the MR to localize that lesion. Consider that this is the exact same patient as the MRI that I showed you before. I didn't borrow this slide from Dr. Patel, but the actual cancer is right there in the anterior transition zone as well. So you see the difference between identical patients with different MRI findings, and this is one of the reasons why the urology community is very interested in MRI and its ability to help not only in diagnosis but also in follow-up treatment. So they both had MR fusion biopsies. 50 to 95% of 5 cores were involved. So how do we guide the management decision? We incorporate the genomics. All my patients also see a radiation oncologist. They're going to go on to have surgery. A nurse practitioner in our practice sees them because she has a way of explaining the keto exercises better than I do. And I think a multidisciplinary approach is essential in shared decision-making model for healthcare as it relates to prostate cancer. So how does MR help further in staging patients before prostatectomy? This, along with clinical information, can be useful in the preoperative assessment. So the patient who had the lesion anteriorly possibly can have a nerve-sparing operation because the cancer is well away from the nerves, as Dr. Kundu showed in the anatomical sketches. The patient with a posterior lesion, however, you probably want to err on the side of resecting the neurovascular bundle on the left side or the side that's involved with tumor. So we know from this study that MRI outperforms other clinical parameters, and those would be Kaplan scores, Parton tables. These are basically nomograms that you plug the data into, and it tells you the risk of there being cancer outside of the prostate gland. It tells you the risk of there being lymph node involvement, and really the MRI outperforms each of those tests. And you see MRI is this green line. It means that the area under the curve, where this area is much more statistically significant than any of the other nomograms there. And then the other thing is tumor contact length with the prostate capsule. If the length of tumor contact in the capsule is greater than 10.1 millimeters, we know that the chances of extraprostatic extension are high. I put the gross diagram in. I didn't have my daughters looking at the slides, so from your son's show. So then focal therapy. If we know that there are lesions in a particular part of the prostate gland, and we've sampled that, remember biopsy samples, if you take 12 cores, it only samples about 0.047% of the prostate gland. So, you know, if you take 85 biopsies in the saturation biopsy realm, you can't remove the entire prostate with a needle. It's just very small samples that are coming out. But MRI sort of opens up the realm of focal therapies, either in the form of cryoablation or high-intensity focused ultrasound, which was recently approved by the FDA. So again, another patient, 62 years old, really concerned about erectile dysfunction. One of my partners at Rush focally ablated this area, focally ablated that area with cryoablation. So in conclusion, MRI continues to evolve in the management of prostate cancer. Incorporation of the pretest biomarkers and MRI certainly aids with smarter screening. If the MRI happens to be normal, the markers are low, then you don't necessarily need to subject those patients to a biopsy because their risk of having cancer is very small. Fusion biopsy, I think we'd all agree, more accurately diagnoses and clinically characterizes prostate cancer. And we follow patients not only on active surveillance with MRI, which in some instances, if the MRI does not change, there's a growing swell of consensus that those patients may not need to be subjected to repeat biopsies on a regimented year 1, year 3, year 5. 60, you don't want to get 10 biopsies by the time you're 75. And MR certainly helps with MRI, with neurosporion and lymph node management. Thanks.